Good afternoon. You are all welcome to the verbal presentations, and we're focusing on rural WaSH. Our first presenter is Catherine McManus, and she's going to speak on financial sustainability of rural water points. Is community management sufficient?
Okay, thank you. Thank you. Hi everyone, I'm Catherine McManus. I want to acknowledge that I'm presenting someone else's work here today, so I can answer questions, but I want to give full credit to Vijay. Vijay Sitana is a former student at UNC who did this work and who couldn't be here today, so I am doing my best to fill in for him. A little bit of background, as I assume everyone in this room knows, there's significant reliance on community management in rural water supply systems. And the historically dominant management model is community-based management, which essentially means, especially as it relates to this work, that there are water committees who are hopefully volunteers, but are community members who are responsible for the technical and financial management of their water system, and with everything that entails, including fee collection, so collecting money, and then hopefully spending money to maintain their water points. On the right, I have a screenshot of the cover of a training manual produced by the government of Malawi, focused on training these committees. But as we've been hearing this week and over the last few years, there's a growing shift in the sector towards what's called professionalization, or I guess this week maybe sort of market-focused approaches to management of rural water supply systems that we're interested in exploring through this work. And this work relates to a lot of the work that has been done related to the functionality of rural water supply systems. So a lot of the academic research has found that, if we're talking about functionality, however that is defined, one of the key determinants of functionality is the collection of user fees. So that the idea is that if we're collecting money, we're able to spend it on maintaining our water points and maintaining the functionality of those water points. And we're not touching cost as part of this presentation. I'm happy to talk about it afterwards, but those costs can be significant. So the expectation placed on whoever is managing water points can be very large in terms of currency. But what this research is really asking is about determinants of those fee collection mechanisms. So we're not asking about performance outcomes like functionality or quantity or quality of supply, but one of the intermediate outputs, which is the financial management behavior of water point committees. The data that Vijay used were collected by the UNC Water Institute in collaboration with World Vision across 14 countries, 12 of which are in sub-Saharan Africa. Oh, you can come in this way. And which were collected at a variety of communal rural water supply systems. The method used is Bayesian network modeling. I will not get too into it, but before anyone gets too scared, it is not Bayesian statistics. It is something that relies on Bayes' theorem of conditional probability, which is basically just about using a bunch of data that consists of all different combinations of every possible state. So as an example, if the grass outside is rainy, and we know the probability that the grass outside is rainy, or is wet, sorry, and we also know the probability that it's raining, we can calculate the probability that someone turned the sprinklers on. So if it's the grass is rainy or the grass is wet and it's sunny, we can calculate in our minds, I mean, we all are doing it intuitively right now, that it's pretty high odds that someone dumped water on the grass. So essentially, on a large scale, that's what Bayesian network modeling is doing to something like this. And it's probably pretty small, so I apologize for that, but essentially, how do I do the pointer? We're looking in here, so we have factors related to the context of a water point, and then down here, a lot of what we typically talk about when we talk about rural water point management, so functionality, how long was a breakdown, things like downtime, frequency and duration. But what we're interested in this study is some of these financial variables, which I'll list on the next slide, which have been shown to be inputs to the performance variables, the performance outcomes that we're interested in. So these are three of them here. So it's whether or not committees collected fees or collected financial contributions after a breakdown, which is sometimes the way that money is contributed to repairs in these situations. And also included information about non-monetary contributions. So in communities where community members are, for example, subsistence farmers, they're able to contribute in non-monetary ways, either by providing labor or goods which can be sold or used as inputs to fund repairs or whatever's necessary. And then finally, we asked about if the respondent, so these were surveys, if the respondent and the committee believed that they had, in their experience, enough money to cover their O&M costs. So this is sort of the goal, right, is that committees are collecting enough money, if not to fund the initial installation of their water point, but to keep it operational. So the survey asked, do you have enough money to do that? And what I'm about to show is a stratification of those results by committees where women were in positions of financial leadership. So a lot of guidance or hypotheses is that if the treasurer of the Water Point Committee is a woman, that there might be better financial outcomes. So we included that, as well as if the chair or vice chair of the committee was a woman. And that's because there are those theories, but then there are also in different countries policies. So for example, I'll talk about Malawi again. It is policy that at least 50% of the Water Point Committee be women. But that's different than that the chair or the treasurer must be a woman. So this was a question really asking about, not about the inclusion of women, period, but about the inclusion of women in positions of leadership. So without further ado, I will show the results. And essentially, at water points with committees where women were in financial leadership, these intermediate financial outcomes were, oh, thank you, I have 2 minutes left, were better than at committees where women were not in financial leadership or where there were no committees at all. And in the interest of time, I will keep it moving, but you know, the headline is that even so, only 44% of committees with women in financial leadership, which is sort of the best group, the best performing group financially, only 44% reported that they believed that they had enough to cover their operations and maintenance costs. So when women are in charge of the financial management, they're more likely to collect fees, they're more likely to collect money after a breakdown in response to need for money, and community members are more likely to contribute in non-monetary ways, but still, only 44% of those committees reported that they had enough to cover even their operations and maintenance costs. So in very quick conclusion, committees are good. Water committees with women in charge of the finances are better. As I noted, this is often encouraged or sometimes even required. But I do want to acknowledge that there have been concerns about this tokenistic participation versus true actual empowerment and leadership. And as I said, it's still not necessarily enough as we're seeing. I want to stress that in no way do I intend to assign blame to those women leaders who are in financial positions. I personally take it as a sign of a limitation of community-based management and of the kinds of structures and the way that these committees operate already. And also, I'm really hesitant to add to the already significant expectation and burdens that are placed on women in these communities, because this is more unpaid labor that we're talking about, and more burdens on their time and social capital. Really quickly, limitations of the study. So we also actually were asking about the inclusion and leadership of people with disabilities on the committees, but actually there was such low incidence of these groups that we weren't able to make any claims. And we don't have a full financial picture, so we don't know about payment rate or collection rate, and the self-reported sufficiency of funds is not necessarily the sufficiency of funds. There's also some issues with causality. It's cross-sectional data, so we can't make any causal claims. And there's also this interesting issue of reverse causality. So the example I have here is there enough money for O&M because people pay their fees, or do people pay their fees because their committee is responsive and provides adequate O&M? So that's a little bit of a tricky one to glean from this study. So I'm well out of time, but I will leave the conclusion slide up. But really the takeaway is when women are in financial management, committees are more successful financially, but not entirely necessarily able to cover costs. And so we're hearing a lot about the ability of external finance or thinking about performance as an input to financing, but at this point, rural water supply may still need subsidies. So, thank you.
Thank you. Thank you, Catherine, from the Water Project. I think we can take questions, maybe one or two questions before we get to the next presenter. Any question? Yes.
Yeah, thank you for this good presentation. And my question really addresses a question around the insufficiency in terms of fee collected to manage operational maintenance. And the question would be then, how do we determine tariffs? If we are collecting fee, what is the motivation, what is the intention of collecting that fee? If at the end of it is not enough to do the operational maintenance. So what lessons do you want to tell us about in this study?
Yeah, thank you. Fabulous question that I would love to talk to you about for much more time than they'll allow. I think my response to that is I'm in complete agreement, and my question back to you is, what level of operations and maintenance are we talking about? The cost is entirely dependent on the level of service that's being provided. And again, not to overburden the committees, but are we including preventative maintenance, or are we only including reactive maintenance? What level of service? And I agree. I think the fees that are being charged are probably too small. That's not a comment necessarily on the affordability, but I'm in complete agreement that the amount is too low. I don't know who should be setting them. I think eventually it should be some type of service authority, a regulatory body that has a grasp on what the costs truly are and can set appropriate tariffs. But I think that's a limitation of community-based management. I mean, we're asking people to collect fees from their neighbors. I think about my neighbors, and I don't know how receptive they'd be to me knocking on their door and asking them, for money. And so I think that's a flaw of community-based management in many ways.
Yeah, thank you very much. It's a nice presentation, and also I really see how women are affecting the water committee arrangement. Actually, I have two questions. The first one is, when we're talking about policy, the 50% plastic, honestly, it is confusing because, like, in one way, like the committee number is an odd number, so how 50-50 is being planned in the policy is the question to be answered, because when we are thinking of 5 members in a committee, it will be 40-60. Why we are talking about 50? That's one of my question. On the financial sustainability element, yeah, maybe the collection or covering of the financial need in O&M can be improved by having women in the committee members. But I believe that sustainability also go on decision making. In that case, how they will affect on the sustainability? That's my question. Thank you.
Yeah. So thank you for the questions. Your first question is a little bit easier about the 50-50. So it's not a requirement that it be perfectly balanced, but that it be at least women. So in your example, the 60% would be the 3 women. They would want 3 women on the committee of 5 people and 2 men. And I think to your second point, I cannot comment based on this research on the how the inclusion of women affects the financial sustainability. One theory that people have is that community members are possibly more likely to trust women. They're more likely to give women their money. Another theory that people have, and again, I can't comment on this in relation to this research. I'm just reporting sort of some theories. But another one is that women are more involved in water collection, and so therefore more personally invested in the maintenance of the water point, and therefore more motivated to make sure that they have enough money in the coffers of the committee. But I can't. We didn't get the opportunity to get into the mechanics. I think that would be really interesting, to understand people's motivations and how these numbers were achieved.
Thank you. For the sake of time.
We can talk later.
Exactly. The 2 extra hands, you do bilateral with Catherine. Thank you very much, Catherine. We are very grateful. So we'll now invite... Yes. The next presentation is by Viviana, Household Level Environmental Risk Factors for Animal and Human Fecal Contamination. Yes. Okay, great.
Sure.
Okay, good afternoon, everybody. My name is Viviana Alban. I'm a graduate student at the University of Washington in the Department of Environmental and Occupational Health Sciences. And today I'm gonna present my work titled Household Level Environmental Risk Factors for Animal and Human Fecal Contamination in Northwestern Coastal Ecuador. In the household environment, fecal matter can be spread through water, food, hands, and surfaces, creating multiple pathways for exposure to enteric pathogens. And infants are especially vulnerable to these exposures as age-specific inappropriate behaviors such as crawling and mouthing, combined with the immature system that they have, increases the risk of these repeated enteric infections and potentially downstream health outcomes. Some of this fecal contamination comes from human sources, and some other comes from animal sources. And this is especially important in low and middle income countries where animals are very important for the livelihood of the people and also for the food systems. And in fact, some of our work have found that animals from the study area where we are conducting this project harbor multiple zoonotic enteric pathogens, including E. coli, some pathotypes of E. coli, Salmonella, Cryptosporidium, and Campylobacter. So distinguishing between human and animal sources is critical to provide interventions that are more targeted and household specific. Microbial source tracking markers, from now on referred to MST markers, are powerful tools that allow us to pinpoint whether fecal contamination is coming from humans or animal sources. So using qPCR, these markers are detecting specific host-specific gene fragments from bacterial or viruses, and provide estimates on presence and absence, and also estimates on abundance. Because human and animal gut microbiomes vary by region, local validation of these markers is essential. So in our previous work, what we did is that we validated 5 different MST markers, including human and animal sources. For animal, including species, swine, ruminant, avian, and canine species. And we were lucky because they turned out to work pretty well in our study setting, with more than 80% of overall accuracy of these markers, which is pretty good. From the same validation study, we also tested these MST markers in more than 10 different household environmental samples, as you can see in the x-axis of this graph. And we found that floors in both child and maternal hands had the highest prevalence of MST markers. So this suggests that these are potentially key reservoirs of fecal contamination in the household environment, and are likely important pathways of exposure in our study setting. So based on these findings, the objectives of this specific study were to first quantify the prevalence and the abundance of human and animal MST markers on floors and infant and maternal hands. Second, to evaluate associations between WaSH conditions and human MST data. And second, to evaluate associations between animal husbandry conditions and animal MST data. This was a cross-sectional study, including 140 households from the ECOMID birth cohort study in Esmeraldas, Ecuador. ECOMID stands for enteropathogens, growth, microbiome, and diarrhea. And the overall aim of this study is to understand how environmental conditions influence the developing infant gut microbiome, enteropathogen burden, and also some health outcomes. For this analysis, we included kids at 6, 12, and 18 months, from which we collected data on demographics, WaSH conditions, survey data on demographics, WaSH conditions, animal husbandry conditions, and also we conducted environmental sampling of floors, household floors, and hands. And we did that to assess animal and human fecal contamination using our previously validated MST markers. For the statistical analysis, we analyzed the MST or microbial source tracking data in 2 ways. So first, we model marker as presence, absence, and for this, we use generalized linear models with a Poisson distribution to calculate prevalence ratios in 95% in confidence intervals. And then second, we also model MST data as abundance. And for this, abundance is referred as gene copies per surface area. So for floors, we normalize the gene copies per the sample area, by the sample area. And for hands, we use a different approach. What we did is that we normalize gene copies by hands surface area, which are provided by the EPI guidelines. And we decided to do this normalization approach because it helps with interpretability of the statistical models and also will help to compare across different sample types. So for MST abundance, we use generalized linear models with a Gaussian distribution, and we calculated mean differences in log abundance in 95% confidence intervals. We ran individual models for each exposure and outcome to avoid multicollinearity. And then we also adjusted all models for infant age, maternal education, socioeconomic status, and community. So one of the key findings of this study was the substantial burden of fecal contamination from both human and animal sources. The bar plot in the left illustrates how the prevalence of the human and any animal MST marker, and these are color-coded by sample type. So overall, we can see that the human marker was detected in 77% of all environmental samples. And these high levels of human fecal contamination were identified despite 90% of our households reporting having access to on-site sanitation in the surveys. And then for the animal MST markers, there were not that prevalent as compared to the human MST data. Here on the right, we can see these density plots that are showing the log abundances of each of these MST markers. And overall, what we can see is that infant hens have higher levels of abundance compared to floors. But also, if we see the MST, human MST markers and the animal MST markers have comparable abundances, which means that even though animal MST markers are not that prevalent, when they are present in similar concentrations as human MST markers. That's not working. Okay.
Did it work?
Yeah, but it went.
Let me see if the clicker. Okay. Let me call tech.
Should we stop sharing and reshare? No?
You can try that.
Sorry about that. Hi, it's not moving. Now it works. Okay, we just needed you here.
I get that a lot. Oh no, it's still doing the thing.
Yeah.
Buffering. Ruh-roh.
Now it's frozen.
Well, there was a problem, so. Alright, give me just a second. Let's shut it down, turn it back on. Yeah, that's a lot of PowerPoints. Okay. Alright, go back to sharing screen 2, and which one was
That one.
yours? This one? Okay. Do the thing. Where you slide 8?
Yeah,
Okay,
but I don't see anything in slide 8.
there we go. Just taking a little while. Just thinking about it. All right.
Questions so far?
Yes. Vivian will be happy to answer any questions we have at this point.
What else can I do here? All right.
Just my presentation, or is
It just looks like a really large presentation, so it's taking up a bunch of memory. Yeah. So
maybe it's on my animation?
possibly. Yeah. So it's just moving a little slow, but it is moving. I can see if I can grab another laptop for you. Maybe we can swap it out. Give me just a second. By all means, keep going.
Anyways, these are the results for the associations between WaSH variables and the human MST markers. So here you're looking at point estimates in 95% confidence intervals, and it should appear here, but this is looking at household variables, urbanicity, WaSH variables, hygiene variables, and sanitation variables. And so overall, in these associations, we're really not seeing significant associations except for one hygiene variable, which is this, the E. coli in child hands. Well, I'm not going to do it in 2 minutes. As you can see here, these are asterisks that showing that this is statistically significant. And so this was significantly associated with higher prevalence and higher abundance of human MST markers.
If you remember the conclusions.
And then, well, yeah, for animal MST markers, we did found more significant associations, and it seems like household conditions were more tied to presence and abundance of animal MST data. So we found that, for example, owning animals, and specifically owning more than 5 animals, was associated with higher prevalence of animal MST markers. We also found that, for example, maternal contact was associated with higher prevalence of animal MST markers. We also found that the feces index, which is a validated survey measure of animal exposure, which uses environmental and behavioral questions, was also associated with higher prevalence of animal MST markers on maternal hands. So we did see different associations, and more associations between animal conditions and animal MST markers. So overall, for risk factors, I had a beautiful figure of the risk factors for human and animal MST markers. For human, we only found E. coli in child hands. For animals, we found more associations. And yeah, so the strengths of this study was that, we used these validated MST markers. We put a lot of work on validating them. We also use both prevalence and abundance of data, so this data is not telling us just the presence, but also how much of that marker is present there. Some limitations of this study, of course, this is a cross-sectional study, so no causal inference. And also, as you can see, no, you cannot see here.
So
but
if you can
yeah, that
wrap
was
up,
the nice
and then we can take 1 or 2 questions and move on.
yeah, so yeah, that's it.
Nice study. Any questions to Vivian? Okay, I see one hand there.
A really great presentation. I'm curious, how do you account to the difference data availability and the effect size, and how they correlate it, and how that influence your result?
Do you mean data missingness?
Data abundance, because you said it shows data abundance, but also like the different effect of different variables.
I'm not sure I quite understand your question.
Maybe I misunderstood, but
Well, we look at 2 different outcomes. We use the same MST data, but we model as first presence and absence, which will tell you the prevalence, and then we also model
Yeah, so I'm curious how like it's abundant, but also like how the abundant number, like how do you account to two different outcomes? You interpret the result.
Yeah, so for example, here E. coli in child hands is associated with higher prevalence and higher abundance. Both are significantly, statistically significant, so we can say that, yeah, E. coli in child hands is a risk factor for not only more markers being present there, but also in higher quantities. So the exposure might be higher because they are in higher quantities, and they're also very prevalent.
Do you see any variation between the two outcomes that you find? Like,
Yeah, in some cases for the animals, animal conditions, for example, the same condition was only associated with prevalence and not with abundance. We did see some of those.
Thank you very much. Well done. Robert? So our next presentation is by Robert from London School of Hygiene and Tropical Medicine. Effect of two community-based interventions on sanitation and hygiene in Malawi. A control before and after trial.
About to swap that laptop out.
Let's see if... Do you want to change the laptops?
Yeah.
We've put all the files on this. So
Yep, that's fine.
Hi. Imagine my slides. My name is Robert Dreibelbis. I'm from the London School of Hygiene and Tropical Medicine. Acknowledge my co-authors on all of this stuff. We got Mindy Panula over there in the back, Kondwani Chidzwazano over here, who's my co-PI, and Tracy Morse. A couple of other people scattered around the conference, and then in the kind of, demarcation of who presented what, I got this presentation, so eventually. So we're going to talk about the impact of two community-based, I don't even remember the title, two community-based interventions on sanitation and hygiene outcomes in rural Malawi. This work was funded by World Vision as part of the larger WaSH for Everyone program, which was a 3-year program implemented by World Vision and Water for People to achieve universal coverage of sanitation and water and hygiene over a 3-year period in Chirazulu, Malawi. This is where I do, here we are. All right. Cool, okay, so, perfect timing. So our study site, this is Chirazulu district. It's a traditional, it's one of the districts in Malawi. We have each of these traditional authorities, so these sub-district levels, that receive different interventions. So in yellow, we had TA in Chema. They received our standard CLTS intervention. I'm not going to explain what CLTS is here. The TA Chitera, they received a CLTS intervention plus the addition of care groups. So these kind of weekly, locally based, kind of self-organized groups that are designed to kind of promote ongoing behavior change at the community level. And finally, TA Nkalo, which served as the control for our study, they received the intervention. After the part of the study, we took advantage of the natural implementation life cycle here. So what we were trying to do with this study was really document the impact of these two intervention models, so CLTS alone plus CLTS with this additional care group on sanitation and hygiene outcomes. We also wanted to compare these two intervention modalities to one another to see if one was performing better. And then, yeah, that's it. Here's our study design. I'm not going to go through it for the sake of time, but this was a controlled before and after study. We had about 11 months between our baseline and end line, and just a note here, because I'm pulling across a couple of parts of the study. We also did direct observation at about 300 households at both baseline and end line, equally distributed across all of our study arms, and we use that to talk about kind of hand washing outcomes. So yeah, on to the results. What did we actually see here? You'll probably have seen these kind of bar graphs. We copied the colors from the JMP report exactly with that little dropper thing on PowerPoint. But we've added one additional outcome here, which I will explain now why. The primary outcome for the project, the WaSH for Everyone program, was sanitation coverage, which was defined as access to a private sanitation facility of any sort. Now, this kind of differs slightly from our JMP definitions, which kind of, start with open defecation onto an, I'm now forgetting how it goes. So an unimproved facility down to a limited facility, which is a facility that would be otherwise improved, except it is shared to, and then up from there. What we needed to account for with this study design was shared unimproved sanitation facilities, which you can see from the baseline results, which is the left-hand side of all of these graphs. This was probably the most common form of sanitation at baseline in all of our studies. But our primary outcomes here are those squares that in red. So anything that would meet the definition of a basic sanitation facility or a private unimproved facility. And what we saw across these, both the CLTS, which is this middle band here, and the CLTS plus care groups, which is the band on the right, both were associated with significant changes in private sanitation coverage. If we translate this into odds ratios, sorry for the over animation there, if we compare the CLTS intervention to the control, households were about 3 times, the odds of a household having an unimproved, having a private sanitation facility at end line were about 3 times higher than households in the control group once we adjust for baseline imbalances between that. And in our CLTS plus, that was about the odds ratio there was about 2.3, so really large gains in this. But if we focus just on this basic sanitation category here, so this is the one that meets our kind of mixed up a little bit here. This is our SDG 1 target of basic facilities. So this is actually not quite what would be monitored within JMP, but this is about as good as we can get in kind of standard things. So the proportion of households who achieved access to a basic sanitation facility didn't change, and we saw no change in any of our intervention arms. Looking at reported open defecation, so all of these is again the control, CLTS, and our CLTS plus arms of this. Baseline levels across all of our groups, baseline open defecation, this is an individual level, not a household level, was incredibly low. It was largest in our control group at about 6%, but in both of the intervention groups, we did see kind of baseline open defecation levels of below 3%. And this is going through every member of the household, asking them where they defecated last time. We do see kind of declines in all of our intervention groups, but kind of no real detectable difference in open defecation among all of our populations. Moving on to access to a hygiene facility, you will note all of those graphs are going in the wrong direction. We saw a decline in the proportion of households that had at least a basic hand washing facility, which is a dedicated location where both soap and water are available for hand washing. A large decline in our control group, but a similar decline in the CLTS group, and more or less a flat change in our CLTS plus care groups. So no real change there, but important to note, we do see quite a bit going on here in that limited hand washing facility. So this is a dedicated location for hand washing where either soap or water are not available. So you're missing one of the key things there. And this accounted for a huge portion of our population in all of our groups. Finally, looking at our direct observation of hand washing here. So this again was a 3-hour direct observation period where we observed hand washing as it relates to predefined kind of hand washing moments or these kind of hand washing opportunities. And again, these we also see things going more or less in the wrong direction. Hand washing behavior at baseline, it was less than 3% of observed hand washing behavior that we saw hand washing with soap. That went down in the control group, it went down in our CLTS group, and it went down in our CLTS plus group. What is important, though, is the parts that did go up or remained relatively unchanged were the proportion of households where we observed kind of inadequate hand washing at these key moments. So hand washing with water only versus kind of using soap. And we see this kind of going up in all of these intervention groups. In both of our intervention groups compared to the relatively large decline in our control group. So really kind of an indication that likely there is some type of initiation of the behavior we want. It might not be the kind of behavioral target that we would hope for, meaning hand washing with soap, but at least there is some type of hand cleansing, really suggesting that soap is likely a barrier within this population. But regardless, these hand washing with soap rates, regardless of the direction they went, it's likely at a level that's probably not of any public health significance. So I just threw a lot of graphs at you. Here I put it in one table and color-coded it all for you. So anything green here, these were we did see significant differences between those intervention groups and the control group, and the yellow where we had kind of these borderline associations. And so it's the CLTS versus control, CLTS plus versus control, and then comparing the two arms to one another. I'm not going to spend a lot of time on that. Just for the purposes of this, they really didn't perform any different from one another. But we do see changes, really large changes in access to a private sanitation facility, but unfortunately not a lot of changes in our other outcomes here. So we've spent a lot of time kind of trying to really understand this and going through this. And the first is, we didn't see a lot of differences in performance between these two arms. And a lot of that comes down to probably what the differences were between the care group model as implemented in this study and the care group model as conceptualized. As part of this larger CLTS intervention, the care groups in this particular round of implementation were more or less used as an extension of the CLTS monitoring. So there wasn't this kind of bespoke behavior change activity that they were able to offer. They were really there to kind of track and monitor differences in sanitation coverage. So it explains why we might not have seen differences in performance between these two interventions. But important to note that this basic sanitation, or at least improved we want better sanitation facilities. We want people in that green or even that other color that's we don't ever do on our SDG graphs because we don't know how to measure that statistically. But we didn't see really any changes within any of these. So neither of these intervention arms really got people to that higher end of the sanitation ladder. And it's really these interventions as they currently exist, particularly CLTS, are just not going to meet our SDG targets if we keep implementing those in the way that we currently are. No changes in observed hygiene behaviors, so, bad news there. I can go through a lot of the other stuff. I'll put this up here and, vamp for a second. These are the two preprints where we have both the sanitation outcomes and the hygiene outcomes. I think I got them in the right order, but I don't know. It's hard to tell QR codes apart. So happy to answer questions.
Thank you so very much for the nice presentation. We'll now take questions, if any.
Back here.
CLTS plus will not get us to achieve the SDGs. Yes.
So Will Tillett from SHA. I was actually in Malawi last week in one area where we're making a lot of progress in WaSH generally in our programming. An area that we are still struggling with is a sort of post-ODF reality and getting market-based sanitation to stick in very sort of low-income rural areas. But also that the progress and the impact on hand hygiene has been sort of stubbornly low. across our program. And so we were thinking about, adding a kind of care group, a kind of a model. These results aren't massively convincing of the cost effectiveness of doing that. And I guess a question for those who are involved on the ground of it would be like, how, if you were to design this again, and it also looked like it was kind of done in a already ODF district, right? If the open defecation rates were low already, right? It wasn't like there was high baseline. And so I guess a key question is just, if it was to be done again, how would it be done differently? And also, was there some learning around, because the care group model potentially has quite a lot of opportunity, but is there any learning about how that could have been done differently to potentially see different, more successful outcomes? Thanks.
Yeah, there were quite a number of things. I've focused on the outcomes here. We have a whole host of studies that have looked at various aspects of this. I do think kind of particularly around the care group model, it was potentially, I don't want to say underutilized, it was a new form of utilization of this, of bringing this kind of existing structure, and through Malawi policy, these care groups have to exist in every community there. I do think in order to use them effectively, we can't just kind of bring them into existing interventions. It requires kind of training, it requires that proper oversight and that proper mobilization and giving them something to do. There's a slight indication, I haven't gone through all the nuances of this, that they are a little bit better at getting out to these households, getting into kind of some of the ongoing behavior change, so these kind of slight improvements where we see in the care group model. And I think a lot of that has to do just the fact they're on the ground, they're still in the communities, they're not doing the whole big song and dance around CLTS mobilization, but they exist for a longer period. So yeah, happy to discuss further. So.
Thank you. Okay, one more.
Thank you. First of all, I think I wanted to know if you could unpack what you mean by care group. What is it in details? But also, we know in sanitation world, it's about behavior change. And in this study, just like in many other studies, when you have a control group, which is 5, 6 districts or locations away from, it will still be affected by the interventions that you are treating in a certain community. Mm-hmm. So in this study, what were some of the confounding factors that you observed in your study? And then the last question is to the moderator.
3 questions?
Yeah, to you, a question to you. Yesterday, and even today, we heard from India.
I didn't make any presentation.
Yeah, because you made a statement. India showed a lot of progress towards realizing SDGs. You just made a comment to say, so CLTS Plus cannot make us realize SDGs.
It came from him, don't worry.
Okay, so I need an answer for that as well. Thank you.
Please, one more. He had his hand up. Yes. Don't give us 3 in one question. And then you answer.
Sure.
Yeah, I'm excited to be part of this presentation. I was part of this project in Malawi. Oh. Yeah, if you saw those big tanks, I was the engineer behind. Yeah, so casually in Malawi, we had been discussing about how effective CLTS has been, or how not. But this presents the picture that CLTS is not working. So I was waiting for the conclusion with the results that we found. So what next? I didn't get that.
Thank you.
I just want to caveat this. I'm not saying CLTS doesn't work at all. We did see massive increases in private unimproved sanitation facilities, which if you think about the sanitation ladder is still progress. It's just not progress that's going to get at the levels that we need for global monitoring. It's not progress in the direction that we're going to get to where we've meet our SDG targets around these. So there was some improvement. I mean, there went up by 30 or 40% of households that had a private unimproved sanitation facility. The health impact of that is a little bit unknown. There's very limited data on that specific transition. Maybe a couple of studies that we've got from Mali that have looked at this, but that's still something that we can't really kind of disentangle right now. It just didn't get us where we want to go in terms of our sanitation, our kind of broader SDG targets. And it didn't see any movement in the hygiene outcomes here. So we didn't see any kind of improves. I should say this is also kind of within the intervention. This wasn't our intervention. So we were kind of the learning partner who was kind of engaging with this. This was implemented by partners at World Vision and Water for People as part of a larger thing. So we didn't really have any control over what the intervention was. As far as the confounding factors go, I mean, we tried to control for that with some of the study design. All of these are adjusted outcomes, so we've adjusted them for household wealth, access to a water point on site. On the preprints, it goes into a lot of what we've actually done with the adjustment, and we've tested some of these models. They're relatively robust. But as far as whether that influenced the control intervention, I guess one important part is the contextual factor here is that this kind of study happened kind of right on the tail end of a really large cholera outbreak in Malawi. So our baseline was there, which might explain some potentially elevated hygiene outcomes specifically at baseline, and we see that could help explain why we saw kind of declines within our control group. But this is, I guess, how science happens. We don't get these perfect experiments. So yeah, happy to discuss more with some of this, but yeah, thanks.
Thank you so very much. Give me a round of applause. We take last presentation for this session, and that's Kennedy from Amref Health Africa. Kennedy? Yes. And he's speaking on WaterStarters, a novel franchise model for sustainable water access in resource-poor settings.
Good afternoon, everyone. My name is Ken Omwaka. I coordinate the WaterStarters program in Kenya under Amref Health Africa. So I'm here to present about the WaterStarters program. Maybe the CLTS Plus was not working because of water, na light touch. So we all know the challenges that bedevil the water sector, and Kenya is not an exception. We still have over 18 million people who do not have access to clean drinking water. That's around 39% of the country's population. And of course, the rural areas are most disproportionately affected, with close to half of the rural population not having clean water. And that is even compounded by other factors. For instance, 1 out of 3 in every rural water scheme is broken down at any one point. There are huge challenges with non-revenue water. As a country, we are losing close to 89.7 million USD annually to non-revenue water. And the growth in access to clean water has been quite slow, with just about 12 percentage points over the past close to 2.5 decades. So we developed this model, which we are calling WaterStarters, as a machine to help us address some of the challenges that we are facing in the water sector. And one of them are issues of ownership, because in the rural areas, development has been development of water infrastructure has been driven by parties external to communities. So the levels of ownership have always been low. There are challenges of financing, which we are all aware about. So how can we unlock private investment, local private investment into the water sector? And then thirdly, with the little resources that we are getting from other external partners, how can we make the best use of those resources so that with the same dollar we can optimize reach and reach much more than standard. So we have a franchise model where we are identifying entrepreneurs within communities, and then we are empowering them to own and run sustainable water businesses in their communities. We have an ambition of reaching 1.5 million people by the year 2030, and of course contributing to the various SDGs, as you can see. So our business model is anchored on three things. As I mentioned, we are very keen on empowering local entrepreneurs, and that is very critical because we want to use the entrepreneurial power of communities to accelerate access and also to mobilize private capital. Secondly, we are using blended funding model, and here we are requesting for at least 15% upfront capex contribution from the franchisees, and then we provide 85%, of which half is a grant and half is a loan that is recoverable from the sales of water. So the 15% actually is a direct investment that we are getting, and so far, out of the 10 franchise projects that we have, we've raised close to 160,000 USD as private capital investment. And then thirdly, we are very keen on leveraging on technology. So our model is technology powered, leveraging on, for instance, green energy to lower the operational costs. We are using prepaid meters and cashless systems to ensure efficiency in how revenues are collected and managed. We are using sensor technology and IoT systems to support preventive maintenance. And we even have monitoring app that supports O&M functions for the franchisees. So in terms of the study, we wanted to see, so how effective is this model and how financially sustainable is it? We conducted a study covering 5 of the projects in one of the counties in Kenya, that is Kajiado County. We used a descriptive cross-sectional design, of course, mixed methods with both quantitative and qualitative data. So for the quantitative data, we collected household data from 1,209 households. On the qualitative arm, we did 15 key informant interviews and 20 focus group discussions. We also did some financial analysis on the performance of the franchise projects, looking at things like break-even analysis, return on investment, and net present value. So in terms of effectiveness, as a WaSH program, this is not new to any of us. It is common knowledge that if you do water access, you are likely to get these outcomes. So we saw, for instance, it contributed to equitable access. 74% of our users were actually from the lowest quintile within those communities. There was quite reliability in the services that are provided. 88% of the households reported that there was no downtime in the systems. It made the water access quite affordable, with decline of as high as 83% in the cost of water. So we have places where we drop the price of water from 30 shillings before intervention to 5 shillings after intervention per 20-liter jerrycan of water. There were significant gains in improving access, with a 44% increase in those with basic access within 30 minutes return trip. And that also translated into significant economic outcomes. We saw that actually 62%, I found this surprising myself, that 62% of the households that are accessing water reported to have started or expanded income generating activities. That was quite good. And then, of course, learning outcomes in schools. For the schools that are served by the franchisees, there was a 14% increase in school attendance. And finally, in terms of health outcomes, only 1% of the households reported to have diarrheal incidents, compared to around 14% at baseline. So this is normal to WaSH projects. But what stood out for us is that the way these outcomes were achieved was more accelerated. They were achieved much faster when we are using the entrepreneurial model as opposed to the traditional model. Then in terms of financial viability, one of the questions we are asking ourselves is, are we able to unlock private capital? Are franchisees able to co-invest in these water systems? And interestingly, all the franchisees demonstrated the capacity to raise the 15%. So as I said, we've already raised around 160,000 USD. In terms of the sales, the projections, the trends are quite promising. Actually, one of the projects has been able to fully meet their loan obligations and have a positive return on investment. So the other thing that we did now was to model and to define an optimal model, because our assignment of 15%, 42 was arbitrary at the beginning. So we are asking ourselves, for this to be affordable, how should that be structured? What percentage of loan should we have? What percentage of contribution should we have? So if you look at this, this was the initial investment, and then we model a minimum viable product investment, which shows that if we could reduce our capital investment by around 23%, from 8.2 to 6.2 million, and then have our loan drop from around 42% to 33%, have our grant increase a bit from the 42% to around 48%, and increase the equity contribution to around 19%, then all the projects become very financially sustainable with a positive net present value and positive return on investment. So in a nutshell, we've been able to see that it is a very promising model and one that is highly scalable. We've seen that beyond just creating access to water, we are able to accelerate other developmental impacts as well. And finally, if we are able to have a leaner capital structure and optimize our model, actually we can make the model more financially sustainable. And then I just request if I could reverse, so that instead of being asked questions, I pose this question, that from your experiences, what do you think we could actually do to make rural water schemes more financially sustainable? And then for your many questions that you have, we can have bilateral talks during the happy hour.
Thank you. Thank you. We've heard your question, but allow us, maybe we need some clarification. Yes. Yes, one? Okay, then I'll take the second one.
Thank you, Kennedy, for that wonderful presentation. I like the model. One question though. I've seen that your price for water reduces incredibly, 83%. That is quite a reduction. And I was just wondering, what happens to cost of the investment in the system? Are the franchisees paying? Are they contributing to cover the capex or not?
They are contributing to cover the capex. So let's say if the total cost of the project is $100, so we'll come with $85, you come with 15. Yeah, then our 85, half is a grant, the other half should be recovered as the project.
So doesn't this reduction in the cost of the price of water have an effect on your ability to recover the capex?
No. Actually, what happens is you get into a community that has access challenges, and so the price is quite high, because by the end of the day, you want to make water affordable and accessible to everyone. And remember, even when we started, actually 74% of the users are actually from the lowest wealth quintile. So you want a model that water is accessible, water is affordable, but also the model is financially sustainable. Yeah.
Okay. Thank you. If government were to expand access, how does it work? 100% by government to provide the infrastructure. Is that a model?
So we are targeting the missing middle.
No, my question is, if we are to wait for government, how does government provide services? They pay for 100% capex.
Yes, yes.
Okay. So if this model works, then we can make a case to government that allow private sector to bring in your 15% or 20%, let the private sector go for a loan, and then rather provide maybe 50% as a grant. Okay. What's the source of your grant?
We still do the usual fundraising from development partners.
Okay.
Supported by.
So if government were to adopt this, then we can accelerate access.
Indeed.
And then also probably enhance sustainability, because once the private sector put in 15-20%, they will make sure it's working well. Okay. On this note, I will say, okay, one more, and then I can thank you. Yes, nice presentation. I like the model.
Really great presentations. The main question was like how to make sure the private sector can have more incentive to work in a rural water system. And I was comparing your presentation with the first presenter, Catherine, who said, seems like the rural water supply will always need subsidy, and your model also rely on around 40% grant. And I'm thinking for financial sustainability, if the private sector is fully in, then government will always need to subsidize the around 40%, and seems like we cannot really have fully privatized rural supply, and seems like this system is actually supporting the first presenter saying we always need subsidy, and all the talk about private sector is actually cannot be separated with the public funding. And I want to know if there is effort to reduce the percentage for the grant, and how would you planning to do that? Thank you.
Yeah, so the reality is that the water sector is very capital intensive, and from the outset it's not attractive to private investment. So what the model does is, let's appreciate that you're actually first of all moving from a position where everything is fully externally or grant funded, and we are now moving to a point where, for instance, in our optimized model, we are looking at around 19% contribution by the franchisees. So that is something that we didn't have. And then we are looking at revolving another around 33%. So we've essentially, just by implementing this model, reduced our grant to around 48% from 100%. So that is already very, very significant. And remember, by the end of the day, the mandate to provide water services falls with government, and the private sector and NGOs and everybody else is coming in to support. Yeah, so that is a reality, but we'll work on reducing that dependency on grants as much as possible. Yeah.
Thank you. So if we are to scale up this model, it means the pace of expanding access will double. Because instead of government providing 100%, government will provide 50%.
Yes.
On this note, we say thank you very much. My takeaway, the first presenter reminded us that when we have women-led committees, performance is much better, even though they are not able to do all the work. And I think the second one of my takeaways is that On the floors and the hands, that is where we have the reservoir of the contamination. And CLTS plus care groups is doing well, but not enough to achieve the SDG. Remember, SDG has a different definition, and we're also looking at 2030. On this note, let's say a big thank you to our presenters, and we are talking about Catherine, Vivian, Robert, and Kennedy. And the participants, you've also done very well. One for the participants. Yes, now we can call it the end of the session. Thank you. Enjoy the rest of the program.